Hi everyone, and welcome to this live demo session. So on behalf of Pharma International Institute, I will be presenting to you a topic on drugs for respiratory disorders. Okay, so usually, what are the respiratory disorders? Respiratory disorders are the disorders that mainly affect the lungs, right? It deals with our respiratory system, the breathing capacity of us. Okay, so the diseases that affect our respiratory system are the diseases that occur with the nose, lungs, and the bronchioles, etc. Okay, so commonly, what are the main respiratory disorders that affect us? Okay, they are majorly the asthma, COPD, which is also called as the chronic obstructive pulmonary disease, and the allergic rhinitis. Okay, so these are the three main types of respiratory disorders that affect us as a human being. Okay, so what is basically asthma? Asthma is actually an inflammatory disease, okay, where the muscles of the airway are tightened. Okay, there's going to be a spasm, and that will result in symptoms like wheezing, coughing, shortness of breath. Okay, and now what is chronic obstructive pulmonary disease or COPD? COPD is basically a chronic, okay, irreversible progressive disease that is going to cause this obstructive airway obstruction and preventing us to breathe properly. Okay, what about allergic rhinitis? It is again rhinitis that is triggered because of an allergen. Okay, we have various types of symptoms that will occur along with this allergic rhinitis, like sneezing, okay, increased flow of water through the nose, etc. So these are the common types of respiratory diseases that are commonly affecting humans. Okay, now a common feature of all these respiratory diseases is the cough. Okay, so we will see in detail about each of these respiratory disorders and what treatments we can give for them. So first, we'll be seeing about cough. So what is cough? Cough is basically caused due to an irritation that is happening at the mucosal layer. Okay, mucosal layer of the pharynx. Now, basically, this cough can be classified into two types, which is the first one is the productive cough. The productive cough, also called as the wet cough. Now, in the productive cough, what happens is that the respiratory secretions or the mucus, or which is also called as the phlegm, is supposed to be excreted out or expectorated out. So that is why it is called as the wet cough or the productive cough. It's also called as the useful cough. Okay, useful cough, where you get rid of the excessive respiratory secretions that is present inside your lungs. Okay, whereas the next type of cough is the non-productive cough. Okay, non-productive, like the productive, the non-productive means from the word itself, you can understand it does not have anything to be produced. It does not have any respiratory secretions to be produced or expectorated out. Okay, it just happens because of an irritation that happens in the mucosal layer at the back of your pharynx. Okay, now this non-productive cough is also called as the dry cough. Okay, it's also called as a dry cough. It is a reflex mechanism to some irritation that is happening inside your pharynx. Okay. Now, here we are going to see about the drugs that are going to be used to treat cough. Okay, so first class of drug is the pharyngeal demulcents. So pharyngeal demulcents means they are the soothing agents. Okay, soothing agents. Like I told you, cough is basically an irritation that happens at the back of your pharynx. So these soothing agents like lozenges, glycerin, syrups, as well as licorice, they help to soothe that mucosal layer and prevent the irritation. So usually it is for the dry cough. Okay. Now next category of drug is the expectorants. Expectorants or the mucokinetics. What these drugs do? They basically increase the expectoration of mucus, increase the excretion of mucus from outside of the respiratory tract. So these type of agents are basically useful for the wet cough. Okay, for the wet cough. Again, in the expectorants category, we have two types of expectorants, which are the secretion enhancers as well as the mucolytics. Secretion enhancers, example guaifenesin, tolubalsam, ammonium chloride, and potassium citrate. what they do, they increase the secretions of the respiratory tract so that this mucus is actually lubricated and can be excreted out. Whereas in the case of this mucolytics, what do? They break down the hard mucus so that it becomes more fluid and can be expectorated out. So examples are bromhexin, ambroxol, acetylcysteine. These agents are very common agents seen in the cough syrups. Okay. The next class of drug is basically the antitussives. The antitussives, also called as the cough center suppressants. So we have a cough center in the medulla oblongata that actually mediates this cough reflex. Okay, especially in the case of this dry cough, these agents are useful for treating the dry cough. And we have a different class of drugs that can be used as an antitussive, which include opioid drugs, the non-opioid drugs that act like the opioids but do not have the adverse effects as that the opioids, then the antihistamines, and also the pulmonary receptor desensitizers. All these agents mainly aim to suppress the cough center in the brain so that it can be used to treat the dry cough. The last one is the adjuvant antitussive. So these are basically helping agents that help in relieving the cough. They are just basically the bronchodilators like the salbutamol, terbutaline. So they also help in relieving the symptoms of this cough. Okay. So that was about the drugs that we had to see about that is used for treating the cough. Now the next respiratory disorder that we would see is the asthma. Okay. Now what is asthma? Asthma is basically a chronic inflammation. That is a inflammatory disease of the airway. Usually happens because of a hyperreactive airway. Happening because of a hyperreactive airway in the people. Okay. Asthma is always triggered by an allergen. Okay. Asthma is always triggered by an allergen. Okay. That is how it is. An allergen is going to attack the airway system and that is going to cause its hyper responsiveness. Okay. Now, what are the symptoms of asthma? In the case of asthma, we know it is chronic inflammatory disease where there are going to be some episodes of acute bronchoconstriction. So bronchoconstriction means when the bronchioles are going to shrink. Okay. And that will create what? Some kind of symptoms like shortness of breath, cough, chest tightness, etc. Okay. So those are the main symptoms associated with asthma where you have inflammation as well as some episodes of bronchoconstriction. So if you have to treat for asthma, what you mainly have to aim at, you have to aim at treating the inflammation as well as the bronchoconstriction, acute bronchoconstriction. So this is the classification of drugs that can be used to treat this asthma. So we have the first class of drugs, which are the bronchodilators. So I told you it is used to treat the bronchoconstriction. So bronchodilators, we have them as the sympathomimetics or the beta-2 agonist, because we know that the airways, they contain the beta-2 receptor, the beta-2 agonists that help in dilating the bronchioles, the methylxanthines, and the anticholinergic agents. Each of this we will see in detail in the coming slides. Okay. Then we have other class of drug called as the mast cell stabilizers. Mast cell stabilizers, especially, they help in preventing the release of inflammatory mediator histamine that can favor this inflammatory reactions in asthma. Okay, another class of drug is the leukotriene antagonist. Again, these agents help in inhibiting the effects of leukotriene. Then we have is the use of corticosteroids. We have basically systemic corticosteroids as well as the inhalation corticosteroids. And our the main drug for treating asthma is basically the inhalational corticosteroids. Why do we use inhalation? So that we can decrease the side effects. Okay, side effects that happen with the systemic administration of this corticosteroids. And last agent, because asthma is an allergen triggered agent, you can use anti-IgE antibodies like the omalizumab in order to treat the symptoms of asthma. Okay, so we will see in detail about each of these class of drugs now. Okay, so before that, let's see about the types of asthma, how asthma severity can be classified based on the frequency of symptoms that occur. Okay, so we can say that we have intermittent asthma. Okay, asthma is characterized as intermittent asthma when there is less than 2 days per week of acute bronchoconstriction episodes. So in that case, in the case of intermittent asthma, you do not require daily medication, but when the symptoms actually occur, you can treat it with a short-acting beta-2 agonist. Okay. Whereas in the case of mild persistent asthma, where you develop the symptoms for more than 2 days in a week, okay, in there you can maybe start long-term therapy of this asthma by a low dose of inhaled corticosteroids. So always remember, long-term asthma control is mediated by this inhaled corticosteroids, whereas the acute symptoms or the quick relief of this bronchoconstriction is basically mediated by this short-acting beta-2 agonist. Okay, we will see in detail about all these drugs in the coming slides. So the next type is the moderate persistent asthma, where you have asthma daily, where you have bronchoconstriction episodes daily. For that type of asthma, we can use a low-dose inhaled corticosteroids along with a long-acting beta agonist. Here, for quick relief of symptoms, you used a short-acting beta agonist. Here, you can use a long-acting beta agonist along with or if that is not working, then you can shift to a medium dose inhaled corticosteroids. And here also, for the quick relief of symptoms, you will definitely use a short-acting beta agonist. Now, the last and more severe type of asthma is the severe persistent asthma, where you will develop continuous asthma episodes. Okay, continuous episodes of bronchoconstriction. So your disease is actually serious. So you will have to add, along with a medium dose of inhaled corticosteroids, a dose of long-acting beta agonist as well. And then, or you can also taper it to a higher dose of inhaled corticosteroids with long-acting beta agonist. And again, for short relief or quick relief of symptoms, you would use a short-acting beta-2 agonist. Okay, so that is the types of asthma. Now we will see each of these drugs in detail, what these drugs are. So first class of drugs, which is the beta-2 adrenergic agonists. So what these agents are basically they are agonists at the beta-2 receptors. Now beta-2 receptors that are present inside the lungs. Okay, now what is the function? These beta-2 agonists, they are going to relax the airway. They're going to relax the airway smooth muscle, and thereby they are going to cause bronchodilation. When bronchodilation happens, what happens? The air can actually properly enter into the respiratory tract, and thereby they can help in achieving this relief of the asthma symptoms. Okay, you can see this picture. So in a normal airway, this much is the space. So in an asthmatic airway, what happens is bronchoconstriction. Okay, and when the asthmatic attack happens, again, there's severe bronchoconstriction. So beta-2 agonist helps in relieving this bronchoconstriction into the bronchodilation and helping in getting in the air. Okay, so we told about short-acting beta agonists. They are used for the quick relief of asthma symptoms. Okay, so their major action or their onset of action is between 5 to 30 minutes. So they give you a quick onset of action, and their effects last for 4 to 6 hours. Okay, their effects last for 4 to 6 hours. These agents, they do not have anti-inflammatory properties. Okay, so they just have only what? Bronchodilatory properties, and therefore they cannot be used as monotherapy in the case of asthma, because we know asthma is both because of bronchoconstriction as well as inflammation. Okay, so these agents are good only for the acute symptomatic treatment or for the episodic treatment of asthma. Okay, otherwise they can be used as monotherapy when there is bronchospasm that is caused because of exercise-induced bronchospasm. Okay, that was about this beta-2 adrenergic agonist, the short-acting beta-2 adrenergic agonist. Now we'll see about the long-acting agents. So long-acting agents, the examples include the salmeterol and the formoterol. So the short-acting agents, basically, their examples were the salbutamol. Okay, salbutamol and terbutaline. Okay, whereas the long-acting agents are the salmeterol and formoterol. So these agents, basically, they give longer duration of action of bronchodilation, approximately 12 hours. Okay, for at least 12 hours, they give you bronchodilatory action. These agents are contraindicated to be used as monotherapy, and they're always used in combination with an inhaled corticosteroid, okay, as a long-term control. For long-term control only, you can use this long-acting beta-adrenergic agonist or beta-2 agonist. Now, what are the side effects of adverse effects of these class of drugs, the beta-adrenergic agonist? They can cause what? Tachycardia. Tachycardia means increased heart rate. They can also cause hypoglycemia, increased blood sugar levels, hypokalemia, decreased potassium levels. Hypomagnesemia. Hypomagnesemia is decreased magnesium levels, and they can also cause skeletal muscle tremors. So these are some of the common adverse effects of the beta 2 agonist drugs. Okay, so they are used for bronchodilation, the short acting agents for acute bronchoconstriction symptoms, whereas the long acting agent along with inhaled corticosteroids for long term control. Okay. Next class of drug is basically the corticosteroids. So we know corticosteroids are basically the main long-term drug. Okay, the agent that can be used for long-term control of any degree of asthma. Okay, so what basically the corticosteroids do? They actually inhibit the inflammatory pathway. They inhibit the inflammatory pathway by inhibiting the action of a phospholipase A2. Phospholipase A2 that is responsible for producing the precursor of inflammatory mediator, which is the arachidonic acid. Okay, so these corticosteroids are going to produce what type of effect? Anti-inflammatory properties inside the airways, and because of this anti-inflammatory properties, the inflammatory reactions like edema or the constriction, bronchoconstriction is not going to happen. Okay, so that is basically this the use of this corticosteroids in the case of this asthma. Okay, so we know that we use what? Inhaled corticosteroids for the treatment of asthma, because for chronic therapy, when continuously when corticosteroids are used, they can actually cause the development of systemic side effects if it is taken systemically. So inhaled corticosteroids basically help us to reduce the effect or the systemic effects of this corticosteroids. Okay, taking this corticosteroids. So again, these inhaled corticosteroids, they are also used along with a device called as the spacer, okay, about which we will see in detail in the coming slides. Okay, now adverse effects are comparatively less in this corticosteroids compared to the systemic corticosteroids in the inhalation corticosteroids. But the only adverse effect that can be caused is it can cause oropharyngeal candidiasis. That is because corticosteroids are going to suppress the immune system, and thereby it can lead to development of candidiasis, which is a fungal disease inside the mouth cavity if not properly used, if you don't rinse your mouth properly after using this drug. Okay, and they can also cause hoarseness or hardness of the voice. Okay, so this is the adverse effects associated with this inhaled corticosteroids. Now, the next class of drugs that is used for treatment of asthma is the leukotriene modifiers. So again, the leukotrienes, they are again another type of inflammatory mediators that actually stimulate inflammatory reactions like causing edema as well as causing the bronchoconstriction. So if you can inhibit the production of this leukotriene, then you can prevent the symptoms of the presence of this leukotriene. Okay, so what are the agents? So how do they act in order to suppress this leukotriene? We have few drugs, which is one is the xylutin. How does the xylutin act? It is going to inhibit the 5-lipooxygenase enzyme. It's going to inhibit the 5-lipooxygenase enzyme that is used to produce these leukotrienes. Okay, and thereby it will inhibit the synthesis of this leukotrienes. Whereas there are other drugs like the zafirlukast and montelukast. Now these drugs, what they do, they are going to act as antagonist of the leukotriene receptors. Okay, they're going to show antagonist at the leukotriene receptors, and they're going to prevent the action of leukotrienes on these receptors. So one agent, xylutin, that is going to inhibit the synthesis of leukotrienes, whereas we have zafirlukast and montelukast that are going to inhibit the receptor that is actually going to on which the leukotrienes actually act on. Okay, then these agents can also be used in the case of exercise-induced bronchospasm. This leukotriene antagonist can be beneficial as well. But mainly their action is to suppress or to cause an anti-inflammatory action. Okay. Now, what are the side effect profile of this leukotrienes? Basically, they can cause hepatic enzyme elevation. Okay, they can cause elevation of the hepatic enzymes. So if you're using it for continuously long periods of time, it is advised that you monitor for the liver function. Okay, to see that if your hepatic enzymes like the SGPT and the SGOT are actually increasing or not, and you have to adjust the dosing. Okay, that is about the leukotriene modifiers. Now next we have is the cromolyn. Cromolyn, comparatively a lesser used drug. It is going to act as a prophylactic anti-inflammatory agent. Okay, prophylactic anti-inflammatory agent. What it is going to do is it is going to prevent the degranulation of mast cells. Okay, preventing the degranulation of mast cells. Now, the mast cells contain an enzyme called as the histamine, an inflammatory mediator called as the histamine, which can actually carry forward this inflammatory reactions. And cromolyn can be used to inhibit that release of this histamine so that it can prevent the effects of this inflammatory reaction. Okay. But again, this agent can only be used as a prophylactic drug, okay, because of its short duration of action. Okay, short duration of action. Again, it has to be used 3 to 4 times. It has to be dosed 3 to 4 times. And you can actually use it as a prophylactic agent before you get an attack of asthma, when you anticipate an attack of asthma. Okay, so there are also mild side effects associated or adverse effect associated with this drug, like cough, irritation, as well as an unpleasant taste. Okay, so that was about this cromolyn. Next we have is the cholinergic antagonist. The cholinergic antagonist examples are the ipratropium bromide and the thiotropium bromide. Okay, ipratropium bromide and thiotropium bromide. They actually function as bronchodilators. Bronchodilators. And they are used in case of asthma, where in some case where people cannot tolerate the short-acting beta agonist. Okay, or patients who have COPD along with the asthma. That is because being an anticholinergic drug, it can decrease secretions. Okay, it can decrease secretions, which is important in the case of COPD, where it's a chronic disease. There's continuous secretion of this mucus. Okay, then these agents, they can be used in combination also with the short-acting beta agonist, okay, which can help in actually causing the bronchodilation. Okay, what are some of the side effects of this class of drug? They can cause xerostomia or dry mouth. Okay, because of its decreased secretion action, because of its anticholinergic effect, and also it can cause some kind of bitter taste inside the mouth sometimes. Okay, so that was about the effect of anticholinergic agents, cholinergic antagonists in the case of this asthma treatment. Okay, so they also act mainly as a bronchodilator, right? Now, the next drug is basically theophylline. Theophylline again comes under the class of the bronchodilators, which under the methyl xanthanes class. Okay, it's a methyl xanthane that also causes bronchodilatory action. It also has additional anti-inflammatory activity, mild anti-inflammatory activity. Initially, in the previous times, theophylline was the mainstay of treatment for chronic asthma. But now when better agents like the beta-2 agonists have been developed, they have less side effect profile and better acting agents, theophylline use has been limited, because theophylline is also a narrow therapeutic drug. Okay, a narrow therapeutic drug. That means even a slight increase of the dose can cause fatal actions or fatal reactions in the body. Okay, so overdose can cause development of seizures or fatal arrhythmias. That is why theophylline use is actually limited now. Initially, theophylline was the mainstay of treatment for this chronic asthma. Okay. Now, next agent is basically the omalizumab. The omalizumab, we saw what it was. It is a monoclonal antibody. Okay, it is developed by the recombinant DNA technology, and it's a monoclonal antibody that can inhibit the action of the IgE immunoglobulin. Okay, the IgE immunoglobulin. So what does these agents do? This agent help in preventing the action of IgE immunoglobulin. Now, what is the function of IgE immunoglobulin? This actually mediates the allergic reactions in the body. So we know that asthma is basically triggered because of an allergen, and that allergic reaction is actually carried forward. The reactions of the release of the inflammatory mediators is carried forward by the IgE antibody. And If you can suppress this IgE antibody, then you can actually suppress the effect of this inflammation. Okay, but the problem of this omalizumab is that it has certain issues that it cannot be used very commonly. One issue is of its high cost, okay, because it's a monoclonal antibody, it is really expensive. Then its route of administration, it has to be taken subcutaneously. You will need the help of a person to take this drug. And also, lot of adverse effects associated with this omalizumab. Adverse effects like anaphylactic reactions, okay, anaphylactic reactions, hypersensitivity, allergic reactions, arthralgias or joint pain, okay. And also in some cases it can lead to secondary malignancies. So only if the other agents are not working, and people don't tolerate the other conventional therapy, then we go to use this omalizumab, which is an anti-IgE antibody, okay. It's a monoclonal antibody. So these were basically the drugs that were used for treatment of asthma. Okay, asthma being a inflammatory disorder of the airways. Now we have a next type of disease called as the COPD, or the chronic obstructive pulmonary disease. Now comparing to asthma, the COPD is basically an irreversible obstruction of the airflow. It is a chronic progressive disease. Whereas asthma was an allergen triggered disease, COPD is a chronic progressive irreversible obstruction of the airflow. Okay. And so we know it is also progressive. Okay. That is why the treatment, that is the difference between these two diseases, even though the symptoms are somewhat same. So symptoms include what? Cough, excess mucus production, chest tightness, breathlessness, difficulty sleeping, as well as fatigue. Okay. So in case of this, even though the symptoms are similar, COPD is basically irreversible airway obstruction because of excessive mucus production. Okay, excessive mucus production, and the main risk factor for causing the COPD is smoking. Okay, smoking is the greatest risk factor that can cause the development of this COPD, where there's chronic inflammation and production of this mucus. Okay. Now let's see what are the drugs that we can use to treat this COPD. Okay, so drugs to use for treating the COPD are basically, first choice of drugs, again we have the corticosteroids. So these corticosteroids, they can be either the inhalational or the systemic ones. So what do? They inhibit the inflammatory reaction. Then we have the phosphodiesterase inhibitor. Again, they have action to inhibit the inflammation and also cause a little bit bronchodilation. Then we have these main bronchodilators, which are again divided into major categories, which is the beta-2 agonist as well as the anticholinergic agents. So the mainstay of treatment for COPD is this anticholinergic agents, because it has an additional effect of what? Of decreasing secretions. So this beta-2 agonist again is classified into the short-acting beta-2 agonist and long-acting beta-2 agonist. Examples are salbutamol, terbutaline, salmeterol, formoterol. Talking about the anticholinergic agents as well, they are classified as a short-acting muscarinic antagonist, the ipratropium bromide, and the long-acting muscarinic antagonist, which is the tiotropium bromide. Okay, now we'll see a little bit about these class of drugs. So the bronchodilators, mainly the bronchodilators that can be used, we know that we have two class of drugs, which is the anticholinergic agents as well as the beta-2 agonists. Okay, so in the case of the COPD, the main choice of drug or the additional benefit would be when you use this anticholinergic agents. Okay, anticholinergic agents along with a beta-2 agonist, because anticholinergic agents have an additional effect of decreasing the secretions. And that is very important in case of COPD, because COPD, there is constant secretions, mucus secretions happening in the respiratory tract. Okay, so the examples are basically this ipratropium, which is a short-acting agent, and the long-acting agent, which is the tiotropium bromide. So the side effect profile we saw in the case of asthma, in case of beta-2 agonists, as well as the anticholinergic agent. So the mainstay of bronchodilators that have to be used in case of COPD is anticholinergic agents, and especially along with this beta-2 agonist, if you can use, you can get a better relief of the symptoms. Now again, we have corticosteroids that can be used in case of this COPD to minimize the inflammatory reactions. So what these corticosteroids do, As we know, we saw in the case of asthma, they can actually decrease the inflammation. They're used to decrease the inflammation. But what is to be careful about using corticosteroids in COPD is that corticosteroids can increase the risk of development of pneumonia in patients with COPD, because in COPD we know that there is excessive mucus inside the airway, and this mucus is a great area where bacteria can thrive. And on top of this presence of excessive mucus, you give an immunosuppressive drug like the corticosteroids. What would happen? It can help in help in enhancing the growth of bacteria inside the lungs, and thereby it can lead to increased risk of pneumonia in these patients. So when it can also treat the symptoms of COPD by decreasing inflammation, it also carries a risk of pneumonia in the case of COPD, but not for asthma, because in asthma there is not much of this mucus production, only when there is an asthmatic episode. Okay, whereas in COPD there is continuous presence of mucus inside the airways. Okay, so that was the action of this corticosteroids on the in case of treatment for COPD. Now, next we have is some other agents, some other minute drugs that can also help in relieving the symptoms of this COPD, which is the roflumilast as well as the theophylline. So roflumilast, again, they are actually phosphodiesterase 4 inhibitor, okay, and they mainly act to reduce inflammation inside the respiratory tract, okay, and it does not have any bronchodilator activity. Whereas in the case of theophylline, again, it's a phosphodiesterase inhibitor. It can cause this decreased inflammation, as well as it is mainly acting as a bronchodilator. Okay. Now, some of the adverse effects of this roflumilast are nausea, vomiting, diarrhea, and headache. So these are least preferred drugs. When the other drugs like the SABAs and the SAMAs don't work, these agents are actually used. Okay. So that was about the drugs that we use for treating this COPD as well. Okay. Now we will see about some inhaler techniques. So we said that this short-acting beta agonist, then inhaled corticosteroids, all are taken in an inhalational way. Okay, so there are basically two types of inhalers by which these drugs can be taken into our respiratory system. The first one is the metered dose inhaler. The metered dose inhalers, or it's also the MDI, where you actually deliver the drug in the form of aerosols. Okay, we are going to deliver the drug in the form of aerosols. So that is an example of a metered dose inhaler. So here you will be punching with your hand. Okay, you'll be pressing with your hand, and the drug is going to be sprayed inside your mouth through the mouth portion. Okay. Then how to inhale this metered dose inhaler when you're using in the form of this MDIs? Okay, the technique to inhale is that to ensure that majority portion of the drug enters into your airway system, you have to inhale slowly and deeply. Okay, slowly and deeply. You have to inhale deeply, hold it for a few seconds, and then exhale out. Okay, so slowly and deeply is the way. Even before you put the actuation or you press the canister for releasing the drug. Okay. So slowly and deeply is the way in which you have to use this metered dose inhaler, where the drug is in the form of aerosols. Okay, because a large portion of the drug that is released from the metered dose inhaler, there is a chance that it can be accumulated in the mucosal lining of the mouth, and this can be swallowed swallowed by the person, and can cause, because especially it is corticosteroids, usually when we take it in the inhalation form, it can cause what can be absorbed from the stomach and can cause systemic effects. Okay, so in order to avoid that, this proper inhalation technique has to be used, where you inhale slowly and deeply so that the majority content of the drug that is administered goes into your airways. Okay, next we have the next type of inhaler, which is the dry powder inhalers. So in the case of this dry powder inhalers, we have the drug that is placed in capsules, or it's in the powder form. The drug is in the powder form, and we use certain devices like this to break open the capsule and inhale the powder inside. Okay. Now, because these agents are in the powder form, the way in which you have to inhale this is basically you have to inhale these agents quickly and deeply so that none of the powder sticks into your mouth, but all of the powder gets into your respiratory tract. Okay, so in both these cases, if in the case of this meter dose inhalers as well as this aerosols, if we have this corticosteroids as the drug, it's essential that we wash our mouth. We rinse and spit out after using these inhalers because deposition of these corticosteroids inside the mucosal lining can cause what? Development of oral candidiasis. Okay, so that was how you have to use this inhaler techniques. Now, next one we'll see is about the spacer. So initially when we were learning about the corticosteroids or the inhaled corticosteroids, we talked about spacer. Now, what is spacer? Spacer is basically, this is what is a spacer. Okay, it is a large volume chamber that is basically used along with an MDI or a meter dose inhaler. It is never used with a dry powder inhaler, but it's used with an MDI. Okay, what does the spacer do? The spacer helps in reducing the velocity of the particles that enters into the mouth. Okay, so when you use a spacer, the benefit is that the large particles that tend to deposit, okay, they will deposit inside the walls of the chamber, and only the small particles that have high velocity, they are going to get into the lungs. Okay, and the next benefit is that because it is going to reduce the velocity, it gives you time for taking in the breath. So people who are having who have to use these inhalers after surgery, or children who cannot take a deep breath, for them these spacers can actually be very beneficial. Okay, so and it is also advised that after using these spacers, we have to wash and keep them dry because of the presence of this corticosteroids, there is an increased chance of development of bacterial or fungal growth inside the spacers, and that can again lead to or trigger this asthma attack or trigger this COPD. Okay, so that was about this spacers, and remember, spacers always used with a meter dose inhaler or an MDI. So next we will see, so that we saw about the drugs that were used to treat asthma as well as COPD. Now here we will see about the drugs or another respiratory disease condition called as the allergic rhinitis. Okay, so everyone would have developed an allergic rhinitis. Okay, allergic rhinitis, which is also called as the hay fever. So what happens over here? Because of a trigger of an allergen like dust, mite, or animal dander, okay, animal or the pollens, whatever it is, it can trigger an allergic reaction in you and then give you symptoms like sneezing, itchy nose, watery eyes, okay, rhinorrhea, nasal congestion, and also a cough. So rhinitis is basically inflammation of the mucous membrane that will give you, that is actually caused because of an allergen, which can lead to these kind of symptoms. So how allergic rhinitis actually takes place? So when you are exposed to an allergen, okay, when you're exposed to an allergen, the allergen will cause mediated through this IgE antibody, it is going to cause the degranulation of these mast cells. Okay, degranulation of these mast cells, which is going to release the inflammatory mediator called as the histamine, mainly the histamine, and also other mediators like leukotrienes as well as various chemotactic factors. Okay, now these agents, what they're going to do, they are going to cause edema, thickening of the mucosal layer, congestion in the nose, and all these symptoms. Okay, so that is basically this allergic rhinitis, and every one of us would have had some episode of this allergic rhinitis. Okay, so what are the mainstay of treatment that can be used to treat these allergic rhinitis? So the first class of drug, because it is actually mediated, or this allergic rhinitis is mediated through the inflammatory mediator called as histamine. The first agent, the main agent that can be used are antihistamines. Okay, antihistamines or H1 receptor blockers. So these, from the name itself, you can identify these are antihistamines that prevent the action of histamine. So thereby it can prevent the development of these symptoms like sneezing, watery rhinorrhea, itchy eyes and nose, etc. Okay, so these antihistamines, we have it in two different classes. The first one is the first generation antihistamines, and the next one is the second generation antihistamines. So first generation antihistamines examples include diphenhydramine, chlorpheniramine, and these agents, the first generation agents, they have some kind of additional adverse effects. Okay, adverse effects like sedation as well as performance impairment. Performance impairment along with anticholinergic activities. So first generation agent, even though they are highly effective in inhibiting the histamine release or histamine action, because of these side effect profiles of sedation, decreasing the performance as well as anticholinergic effects, it is not commonly preferred. Whereas we have another class of drugs called as the second generation drugs, second generation antihistamines like the fexofenadine, loratadine, cetirizine, desloratadine. These agents, they have a similar action of inhibiting this histamine as that of the first generation, but they do not have the side effects, major side effects like sedation or impaired performance as that of the first generation agents. So these second generation agents are preferred choice of agents for treating this allergic rhinitis. Okay, so that is about the first generation antihistamines and the second generation antihistamines for treating the allergic rhinitis. This is the first class of drug. Now, next one is we have the corticosteroids. Again, corticosteroids, it is an anti-inflammatory agent. So it can help in relieving the inflammation that is going to take place inside the nose or inside the nasal mucosa. Okay, so these corticosteroids, when it's used for allergic rhinitis, it is used as nasal sprays. Nasal sprays or intranasal administration, not inhalational. When it's inhalational, it basically gets into your respiratory tract, into your lungs, and it can help in treating asthma and COPD. Whereas when you use corticosteroids for allergic rhinitis, only this local action is required inside the nose. So it can be given intranasally or as nasal sprays. Okay. Thereby, it can relieve these symptoms of this allergic rhinitis like this sneezing, itching, rhinorrhea, etc. Okay. But what are some side effects? If you use chronically these intranasal corticosteroids, it can cause what? Nasal irritation. It can cause nasal irritation, nosebleeds, sore throat, as well as sometimes nasal candidiasis itself. Okay. So that is about this intranasal corticosteroids. Okay, when the symptoms are very severe, only then we use this intranasal corticosteroids. Now, next class of drugs for treating this allergic rhinitis is basically the alpha adrenergic agonist. The alpha adrenergic agonist, or they're also called as the nasal decongestants. The nasal decongestants. Examples include phenylephrine as well as the oxymetazoline. Phenylephrine and oxymetazoline. Now, what these agents do, they are actually alpha agonists. So, what they do, they are going to constrict the dilated arterioles, constrict the blood vessels that is associated along the nasal mucosa, and constricting these blood vessels help in relieving the congestion or opening up the nasal passage so that the air can actually flow into the nasal passage, and thereby they can help in relieving this nasal congestion. Okay, so these agents, they are also used as a nasal spray and they have rapid onset of action. Okay, and they can give you a great relief, especially in the case when you're sleeping. Okay, you can relieve this nasal congestion and that can lead to a good sleep. Okay, now what are some adverse effects or some bad effects about this alpha adrenergic agonist is that if you use it chronically, okay, if you use it continuously, especially for longer than 3 days, okay, longer than 3 days of this alpha adrenergic agonist, it can lead to development of this rebound nasal congestion. Rebound nasal congestion, which is also called as the rhinitis medicamentosa. Okay, it can cause rhinitis medicamentosa. That means the nasal congestion is not going to respond to this alpha adrenergic agonist, but it's going to come again. Okay, it's going to come again because of overuse of these alpha adrenergic agonists. Okay, so these agents, even though it gives you a good relief. Chronic administration or longer duration, longer use of these agents can cause this rebound nasal congestion. So these agents are actually used as inhalational in an inhalational route. Okay, they are never used systemically because using systemically can increase the systemic side effects. Okay, systemic side effects. What are the systemic side effects of alpha adrenergic agonist? It can constrict blood vessels. Okay, it can constrict the blood vessels and thereby it can cause blood pressure, increasing the blood pressure. Okay, so that is the third class of drugs which is used for treatment of allergic rhinitis. Okay, so we saw for allergic rhinitis, antihistamines are used, corticosteroids intranasal are used, as well as the alpha adrenergic agonist or the nasal decongestants are used. Okay, so that was about this respiratory disorder chapter. So here we have come to the end of this chapter. Here what did we learn? We learned about the main respiratory disorders affecting our respiratory system, which is the asthma, COPD and the allergic rhinitis, and the common class of drugs that can be used in relieving these diseases. And also we also saw about drugs that could relieve the symptoms of cough. We saw the types of cough and what type of drugs can be given for relieving these cough. So that is it about this chapter. Thank you so much. I hope I've given justice to this topic and you've understood about this respiratory diseases as well as the drugs that can be used for respiratory diseases. So thank you everyone and have a nice day.